Welcome to this ASAIO journal webinar presented in collaboration with CTSNet, Extracorporeal Cardiopulmonary Resuscitation, Building the Team for Success. Thank you for joining us. Please note this webinar is being recorded and will be available next Monday on ctsnet.org and CTSNet's YouTube channel. At this time, I'm pleased to introduce the host for this webinar, Mark Slaughter. Dr. Slaughter, Editor-in-Chief for the ASAIO Journal, is a professor and the chair for the Department of Cardiovascular and Thoracic Surgery at the University of Louisville. He also serves as the Director of Heart Transplant and Mechanical Assist Devices at the same institution. Thank you for joining us, Dr. Slaughter. I'll turn the panel over to you.
Thank you very much, John. And we certainly want to thank CTSNet for all their help and support with these webinars. We've had tremendous success and turnout so far, and it looks like already we have over 100 participants with additional people logging in. We think it's a very timely and important topic. There's tremendous interest in ECMO and CPR. We always want to try and save lives. We want to do what's best for patients. And when we have technology that we can use, it though also opens the door for ongoing sort of issues, problems, who's the best patients. So we've got an expert panel today to sort of help programs to decide, should they start a program? If they do, what do they need? What are pitfalls? And who are the best patients and have the best chance of survival and success? So having said that, I'd like to turn it over to Dr. Adam Protos, the Chief of Cardiac Surgery at the University of Mississippi, who's going to lead us through this exciting conversation. Dr. Protos?
Thank you so much, Dr. Slaughter. Yes, I'm Adam Protos, and as Dr. Slaughter pointed out, we're extremely excited to bring you guys this webinar on ECPR. We're all kind of learning together. It's a frontier of cardiac surgery and extracorporeal life support. So with that, I'll introduce my fellow digital moderator, Dr. Ashok Kumar CJ, who is my partner here at the University of Mississippi Medical Center and is also the chief of aortic and coronary surgery, and he'll be manning the Q&A portion of the digital Q&A portion of the webinar. And then I'll introduce our panelists here in the order in which they'll present their talks. The first is Dr. Jeff Keenan, who's an assistant professor of surgery at Duke University Medical Center with a special interest in MCS. He'll be presenting first. Dr. Brittany Zwischenberger will be presenting next. She's an assistant professor of surgery also at Duke University Medical Center and has been spearheading a variety of quality projects in addition to all things cardiac surgery. So welcome, Dr. Zwischenberger. And lastly will be Dr. Jason Smith, who is a professor of surgery at the University of California, San Francisco, and is also the director of the MCS and heart transplant program there. So welcome, Dr. Smith. And just some quick housekeeping issues before we get this kicked off. We will open each presentation to the panelists and then follow it with a brief poll question in which the audience is invited and very much encouraged to participate. It's a great launching point for discussion. We'll follow with 5 to 10 minutes of discussion following each presentation before we launch into the next one. And please use your Q&A function on your webinar link to submit questions that will be then edited and asked by Dr. CJ. So with that, I'm excited to turn the talks over to our first presenter, Dr. Jeff Keenan.
Okay, thank you, Adam. I'm going to go ahead and try to share my screen here. Is everybody able to see that presentation? Are you all able to see that?
Yes.
Okay. So thank you for the introduction and thank you for the opportunity to participate in this discussion. I'm going to be talking about ECPR, technical pearls and indications. So I have no disclosures. I thought it'd be useful to start with the definition. I think when evaluating the literature on this topic, one of the real challenges is from study to study, there's inconsistency with how ECPR is defined. That can make it challenging to compare results and also have a sense of where your own results should lie. So one proposed definition from ASAIO is that ECPR is the application of rapid deployment via ECMO to provide circulatory support in patients in whom conventional CPR is unsuccessful in achieving sustained ROSC. And importantly, they specify that cardiac arrest requiring CPR, but with sustained ROSC, which they define by no chest compressions for a period of 20 consecutive minutes prior to ECMO cannulation, doesn't fulfill this definition. And I think those of us who practice in this field know that in real life, it's often not a totally clear-cut situation, and there's really a spectrum of patients in a peri-arrest state that we might consider cannulating for ECMO. On the far end of that spectrum, of course, is really truly the patient in refractory circulatory arrest, where there's ongoing chest compressions while you're cannulating. And certainly that would qualify for ECPR, but short of that, we've also encountered situations where patient has experienced arrests or maybe multiple arrests with intermittent periods that were short in ROSC, where you might cannulate as well. And so defining exactly the point of what is ECPR and what is not can be a little arbitrary. And I think that's just important to keep in mind as we're evaluating the literature, because we're not always comparing apples to apples, study to study. I did want to bring to light this one study that I think forms a useful reference point as we have this discussion. And this was published in the New England Journal earlier this year. It was a randomized comparison in the Netherlands of standard CPR versus ECPR for refractory out-of-hospital cardiac arrest. And so I'm by no means an expert in the Netherlands healthcare system, but I do understand they have a nationalized system, and this was a national trial, multi-center. They apparently have a very advanced first responder type system where they've standardized resuscitation process and also possess the ability to rapidly get patients cannulated for ECMO when they arrive to the hospital, which is remarkable. And I think this study was quite a remarkable undertaking. They ended up enrolling 133 patients, and interestingly did not find a difference in survival with favorable neurologic outcome between the two strategies. Survival with favorable neurologic outcome was 16% in the conventional group and 20% in the ECPR group. I don't present this study to sort of try to state or exclaim that ECPR doesn't have a role in our modern practice. That's not the point. I can certainly think of a patient or a handful of patients, as I'm sure many of us can, where we know ECPR was the difference between a survivor and non-survivor. But I think does highlight 2 points I want to make. The first is I have often thought in the past that when I'm asked to cannulate someone in an ECPR situation, that the decision is between either letting the patient die or giving them a shot with ECMO. And the results from this study would contend that that's not necessarily the case. They have 16% survivors in the conventional group. There's certainly a group of patients that might qualify for refractory cardiac arrest that ultimately were salvaged. And that leads to the second point, which is, one reason that the investigators here concluded that there wasn't a difference was that their survival in the conventional arm was much higher than anticipated. And I think that should actually be viewed as a positive thing. So if you have good processes in place for conventional ACLS, then the marginal benefit or use for ECPR is going to be less, and that's not necessarily a bad thing. And it's an important thing to keep in mind when we evaluate, well, when do we say yes and when do we say no? And a lot of this decision-making ultimately falls to the surgeon or the proceduralist who is finally deciding to cannulate or not to cannulate. And that's a pretty heavy burden to fall on one person. And I think it highlights the importance of thinking about this in advance and developing practice and institutional guidelines about who exactly you would consider and what parameters would lead you not to cannulate in advance. And so I put up our institutional guidelines. I'm not going to go in detail because my colleague, Dr. Zwischenberger, is going to talk in much more detail. But I think it is important to stress that having some guidelines in place is very useful, not only for how you're going to practice, but also alleviating the burden for the person who ultimately has to make a tough clinical judgment in a high stress situation with very limited clinical information. I think it's important to keep in mind also that I don't think it can be stated to any degree that ECPR is a standard of care therapy. High quality ACLS is the standard. So it's not as though you're denying someone standard of care therapy when you are employing ECPR, but rather I think it should be viewed as a more exceptional therapy that is utilized in selected situations. If you are going to make the decision to carry out ECPR in your program, of course, it's important to have a good system in place that allows for rapid and safe cannulation. This is obviously a time-sensitive therapy, and you need to call together a lot of resources and staff in very short time. I'm also not going to belabor the details here because Dr. Zwischenberger is going to talk in depth about the system that we use here at Duke, but ultimately need to rapidly activate and assemble patients. We use a mobile team. And in response, the surgeon assistant, scrub nurse, and circulating nurse, ICU nurse with ECMO supply cart, perfusionist with primed ECMO pump and circuit all need to assemble at the patient's bedside or wherever they are in the hospital to rapidly carry this process out. So a lot goes into it, as you can imagine. So how do we actually get the patient on ECMO? What I'm going to describe here, I know there's a lot of words on this slide, but I figured I'd just lay it all out there so people could read as I spoke over it. I'm going to describe the non-post-cardiotomy situation. Of course, this differs from the post-cardiotomy situation where usually the patient is going to be going down the CALS open chest pathway. And this is more of a de novo shock, non-post-cardiotomy, where you're trying to rapidly get the patient on peripheral ECMO. So I mentioned this is a very much a team endeavor. Clearly, no one can do this by themselves. And a very important component of that is that the ACLS needs to continue by the code team. Sometimes when we assemble and we get to work as the ECMO team, there can be instances where the code team begins to defer management to our team, which we really actually don't want. We need to rely on the code team to continue to carry out high quality ACLS so that we can focus on the ECMO cannulation process. We generally try to limit any interruptions to chest compressions to very brief periods of time where a still field is needed during critical procedural components. But we prep and drape bilateral groins. Our mode is to cut down on the femoral vessels. So outside of the ECPR situation, my preference is definitely percutaneous access. I think it gives more stability and less bleeding issues in relation to the cannulas. But really the only time we consider percutaneous in the true ECPR situation is if there's already groin access in place. We've just found it's been more expedient and feasible with a cut down and then a limited sharp dissection to identify and expose the anterior femoral vessels. Heparin needs to be administered at some point, and then we use introducer needles into the femoral artery and vein, followed by the passing of working wires. We tend to use a Rosen wire, which is stiff enough to give enough body to allow the passing of cannulas and dilators, but also flexible enough where I think vascular injury is mitigated, because of course this is often done in a blind circumstance without adjunctive imaging, fluoro or ultrasound. We then use Seldinger technique to pass cannulas over the wire into the artery and vein. Our default selection for cannula is a 17 French femoral arterial and a 25 French multi-stage femoral venous. That will work well in the large majority of adult patients. It may need to be adjusted based on patient size. Wet-to-wet connection of the cannulas to the circuit, followed by initiation of ECMO. And so at this point, usually we'll have the assistant just hold the cannulas secure because there is a period where I think it's useful to take a period to try to optimize your flow. It's usually a pretty dynamic situation. The patients also often require volume to allow adequate venous return and prevent chugging to achieve adequate ECMO flows. There's also usually pretty dramatic changes in blood pressure that you need to manage as the epinephrine that's given through the course of the code begins to circulate more readily. And it's also an opportunity to try to restore normal rhythm. Once you're flowing on ECMO, you may want to empty out the heart further with additional compressions and try to restore a organized rhythm if the patient's having ventricular arrhythmias. From there, once you're kind of in a pseudo-stable state, we'll proceed with securing the cannulas. We usually place a 4-row Prolene per string on a Rommel at the cannula entry points to limit bleeding, and then many securing stitches. Always tell the residents at least 3 high-quality securing stitches for each cannula. We nearly always always place a distal perfusion catheter. Of course, in the ECPR situation, the first mission is to get the patient stably supported on ECMO, but thereafter we'll put in a distal perfusion catheter. I usually use a 6 French sheath and place it in antegrade fashion into the SFA with an accompanying high flow stopcock and tubing. This has really helped us avoid lower limb ischemia problems on the cannulated side. Then there's hemostasis, followed by temporary wound closure. We usually just do a 2-0 running nylon, and then confirming good cannula position on X-ray. Of course, this is often done blind, so it is important to verify your cannula is, particular venous cannula is where you want it. So I know we're running a little short on time here, so I'll run through this quickly, but those of us who do this sort of work are well aware that getting the patient on ECMO is really just the beginning. The hard part is then getting the patient off ECMO. So, I've listed in the schematic there on the right, there's really 3 major pathways to liberation from ECMO, and that is native recovery, heart transplant, or durable MCS. And it's my feeling that all three strategies should be investigated and aggressively pursued from the beginning, because you just never know exactly where things are going to go. That begins with an aggressive pursuit at optimizing the chances for native recovery. And so this includes an aggressive diagnostic and interventional approach, targeted at the etiology or determining the etiology and then addressing the etiology of the code. So if it's an MI, that might be angiogram and PCI. If it's an SPE, CTA protocol, followed by some sort of thrombectomy, that can be operative, but I will say our interventional radiologists really have gotten tremendous results with suction catheter-based therapies. If you're having ventricular arrhythmias, certainly worth considering ablation. Important to optimize hemodynamics to support end organ function, and unloading the LV is critically important. ECMO, of course, adds afterload to the LV, and the LV is usually not in great shape, so it's apt to distend, which causes a second myocardial injury, and also can lead to pulmonary edema, which adds to the list of problems. So after getting the patient on support, we will often assess the LV for adequate decompression. If it's not adequately decompressed, the best way to deal with that is with an Impella. This can be an Impella CP or Impella 5.5. It can be run at a low speed, just enough to keep the LV decompressed and avoid distension. Short of Impella, you have inotropes and balloon pump to help. I think it's also important to pursue the possibility of transplant and MCS. You never know how these patients are going to evolve, but you want to know if they clinically do evolve into an advanced heart failure candidate, whether or not that's an option for them. And so kind of engaging the evaluation team early on, I think, is important. And then, of course, assessing neurologic status once you have the patient stabilized is also important, because brain injury is often the limiting factor. And if there's issues or concerns there, we're apt to get neurology involved early and pursue head imaging and other modalities to assess that. So I'll just finish up by just presenting a little bit of our experience. This is pretty limited data, but this comes from the ASAIO registry, which we participate in. Over the last 3 years, we've done about 450 ECMO runs at our center. So a fair bit of ECMO, 284 of that is VV or pulmonary, 178 is cardiac, and then 64 is ECPR. And so we perform about at expected benchmarks for pulmonary and cardiac, not quite as good with ECPR. Our survival rate over 64 ECPR runs is 23%. If you look at the ASAIO registry, more globally, it's 32%. And so Dr. Zwischenberger is going to talk a little bit about our evaluation process on that. We're certainly investigating and taking measures to see if we can improve our process there. I think ultimately a lot of it boils down to how you want to practice. I think the more liberal you are with the application of this therapy, certainly it's tougher to achieve good outcomes. And a lot of that has to do with just the nature of the practice that you want to take on. Anyway, with that, I'll finish, and I thank you very much for your attention.
Great. Thanks so much, Dr. Keenan. That was a great talk. This is our first poll question. It's just going to start we're going to start with the fundamentals. Do you have an ECPR program at your hospital? Okay, please respond. We'll try and keep this to about 30 seconds. Because we're running a little short on time, we're just going to go back to back with the presentations and poll questions, and then we will have a panel discussion at the end, at the conclusion of the third talk. I am curious, while we're waiting for the poll to finish, Dr. Keenan, have you guys, obviously the kind of $64,000 question here, and the ones that we all wrestle with are really the out of hospital arrests that come in because so little information is known. Are you guys really limiting your initiation of ECPR to witnessed arrests? And I'm sure we'll talk more about the criteria of that later. This is a question that's on everybody's mind, is, how do you parse these patients out?
Yeah, so I'd say we're moving to doing that. And I think Dr. Zwischenberger will talk more about our process. But when we've evaluated our outcomes and found those times when we're successful and sort of consider them against the times we're not successful, the times we're successful with any sort of unwitnessed arrest is just incredibly rare. You just have such a limited time frame, and there needs to be really high quality ACLS early on. We just have not really had success in that situation, and we've had very limited success without a hospital arrest that come in through our ED. We still do that. We will take calls from the ED and in very selected situations pursue ECPR, but again, it has to be sort of a more optimal candidate, or that's certainly the way we're moving.
Yeah. And I think and we'll discuss that more in Dr. Zwischenberger's talk, I'm sure, but I think it's important to have those guidelines in place from a systems perspective, so that you're not trying to make those decisions when the house is on fire and everybody's panicking. So, okay, that's a great segue into our next talk. I will turn it over to Dr. Zwischenberger. With that, take it away, Brittany.
All right, thank you so much. Let me get my slide shared. Oops. Okay, can you see them? Good. Okay, great. Okay, thank you so much for inviting me to present. This is a huge honor, and I love being able to partner with Dr. Keenan to share what we've learned, which is a lot. So I'm going to present specifically about using your data to look at outcomes and making decisions about your program from there. So we had always submitted our data to ASAIO and did all the cross the T's, dotted the I's for ASAIO, and then we would take that data and we would present it to our surgeons, and we were trying to do all of the usual stuff to improve the ASAIO outcomes, wound infection and stroke and stuff like that. And we just weren't moving the needle as much as we wanted to for our ECMO ECPR outcomes. And so, and this is really for all of our ECMO. So we decided to create a more sophisticated data analytics system that benefits our patients as well as our ASAIO ratings. So we had to take a strong look at the data, and really we've applied this to our adult cardiac surgery program, where we're taking this registry data, which is very clean, adjudicated, and gets submitted to a registry, and then harnessing that power for output for research, quality improvement, and hospital metrics. So at least our conversations with Duke Hospital, it's not what they're running on the back end through the medical record. We get to paint the story, we get to tell the narrative of what we're doing for our patients and the program. So using this data, we decided to mission ODE, observe to expected. How can we affect both sides of that? And it's multifactorial, cleaning the data, identifying the high impact risk factors for outcomes, someone with a preoperative stroke, create multidisciplinary task forces, and then regularly review this data, include both the leadership, but then also the stakeholders, the surgeons that are putting the cannulas in, the nurses, the APPs. And then really focus on education of our APPs, the nurse practitioners and PAs, who are really the foundation of our cardiac program. They're always here, and certainly the nurses, and then improve our capture, our documentation of risks in the medical record. And so the goal is to improve the ODE, but then also the outcomes. So we started with, this is what Dr. Keenan just presented. We made to help the surgeons with their decision making, looking at the data. This was one of our earlier versions of the guidelines. So we'll go into greater detail, but so witnessed circulatory arrest and immediate high quality CPR. So that's different than somebody, we cannulated before, somebody who arrested it was witnessed arrest at home, and then apparently got some high quality CPR. The timeline varies. Predicted total low flow time less than 60 minutes from arrest to VA ECMO flow. And that is going to include a 30-minute time to cannulate, right? Because you deploy the page and then the nurses have a 30-minute lead time before they have to be at the bedside. So some of our nurses do live that far away. And so we have to calculate that when we get the phone call from the bedside. Age less than 65, etiology, it's cardiac, it's not hypovolemic or distributive shock, no major comorbidities, end-stage renal disease, advanced COPD, liver disease. The patient agrees to blood products or has historically, and no obvious barriers to heart transplant or durable mechanical circulatory support, and full code. And as Dr. Keenan said, ECPR is not a standard of care. High quality ACLS is the standard, and it's appropriate to reserve ECPR for select situations. So this is what we were carrying in our head. And then we've become even more specific every time we do a deeper dive into our data. And as we've made it cleaner, as we've become more sophisticated in the way that we organize it, we've been able to revise ours even more. And so this witness circulatory arrest in hospital, no more than 15 minutes in duration at time of ECMO consideration. And so we now feel that this is something that we can provide to the emergency room, right? Like this is very detailed because they just kind of blew our other guidelines to the side. So, and then high quality CPR with evidence of effective chest compressions on art line, entitled CO2 and distal palpation. So again, that takes the pressure off us to try to guess what's happening outside of the hospital. Less than 65 full code, this old, our kind of simple absence of known major comorbidities, but then we got even more specific, not on hemodialysis, no trach, no home oxygen, no limited life expectancy, which means cancer, which is not uncommon when we get called, not transferred from an LTAC or nursing home. So this was exactly what Dr. Keenan referenced, that we traced the patients and where they came from, and our outcomes were terrible for that group. Of course, okay for blood products, no barriers. BMI less than 40 unless a pulmonary embolism patient with intermittent ROSC or an OB patient. And arrest is not due to distributive hypovolemic or anoxia. And then cardiac activity is present, patient is not asystolic. And so we're just starting to execute on these. And of course, there's always the surgeon discretion, but it's very helpful to have this in hand when we're having a conversation. And so that's how we've used the data to help the surgeons with their decision making. But what about the rest of the system? So what about the execution of ECPR? We did look at our survival, and our survival for any ECPR outside of the cardiac ICU or the OR was half. Okay, so if you got cannulated on the floor in the emergency room, the survival was half that of the ICU and the OR. And of course, we have a sense like yes, that makes sense. We have all of our resources and we have all of our people in the OR and in the ICU, but maybe we can do a little bit better, right? Maybe not half survival. So half of the other survival. So we decided our key metric was to improve survival for ECPR outside of the ICU and OR. And we wanted to identify and plug the holes in the system. So the Swiss cheese model. We invited the stakeholders, the nurses, the code team, the surgeons, front desk, who sends out the ECMO page, the APPs and the ICU team to the table. And we started to really drill down to all of these little questions that come out of an ECPR situation, right? So like you finish the ECPR and you think of all the 30 things that you wish had gone differently. And we started to write those down. And we came up with questions like, wait, who actually did ask the surgeon about ECMO? Is it the resident of the APP? And the APP says it's that one, the resident says it's that one. Who brings the ECMO card? That was a big obstacle. And what's in the ECMO cart? Well, the person who's putting the ECMO cart together thinks it makes total sense. It's completely logical, but it doesn't translate to every person, the nurses and the OR nurses. And then a common one was, we need more light, right? The ECPR is always done in the dark. So we created this code, so CT surgery code bleed on the floor. So what was really a pivotal moment is when we got the code team involved, because as Dr. Keenan alluded to, the surgeons would show up and the code team would, wash their hands and walk away, and we're sitting there trying to cannulate and resuscitate and do everything. And so we partnered with the Duke code team and actually came up with an algorithm for them to know how to resuscitate our patients. So, they normally follow the ACLS, which is great and very important, but for ECMO patients, they always need volume, they always need blood, they always need epi drips. So we've given them a card and said, for our patients, do ACLS, but also please do this. And that's taken a lot of the onus off of us and allowed us to move along. So this is the workflow that we've come up with. It's this slide and then the one afterwards. So any patients who arrest as a cardiac surgery patient, and you can apply this, to other patients as well. This is just a starting point, but a cardiac surgery patient outside of the ICU, code blue bell is pushed. BLS is initiated. The APPs who are always in-house comes to the bedside, and it is their responsibility to call the attending surgeon, which they usually did, but they have to specifically say, is this an ECMO candidate? Instead of just FYI, the patient's coding, gotta go, bye. So we do have this question. Are they an ECMO candidate? The BLS is initiated. The Duke code team is simultaneously showing up, starting to run ACLS. The attending surgeon says, yes to both, or yes, proceed with open chest and or ECMO. And then, so once we decide to execute on ECMO, the APP will call the operator and say, okay, yes, deploy the ECMO page, right? Because this was another back and forth. Well, is it the resident who's deploying it? The CT surgery fellow will update the attending and make a plan about cannulation strategy. One thing that we haven't completely unraveled is fellows cannulating by themselves. Right now, the attendings want to be present for cannulation because there are a million things that can go wrong. So that might be our next QI focus. And then the ACLS is run by the code team. So like I mentioned, try to get central access. So, you can actually add a component to your ECMO cannulation to give volume with your cannulation strategy. And so if you can't get central access or there is no central access, then that's a conversation you can have with the perfusionist. Hey, make sure you connect that volume line. Give a liter of crystalloid. Again, this is just a starting point for the code team. 2 units of red and an epi drip. And then the ICU charge nurse is in charge of bringing the ECMO cart. So that was a key component. We've tried to create cheat sheets because, again, the code cart was set, the ECMO, so we have a code cart, an open chest cart, and ECMO cart. The ECMO cart was put together by, OR nurses, and they know all the language. What's the keeper? Where do they go? And it was initially configured to make total sense, but it didn't make sense if you weren't an OR nurse. And so we've created these cheat sheets, as Dr. Keenan mentioned. These are the cannulas that we always use. So it's on a little card, and you point to it and say, yes, those. We don't need to overthink the size of the cannulas except in specific situations, and then central cannulation for an open chest. And so this was really key, was maintenance of ECPR education. And this was another pivotal point, because when you go to the team, or I'll speak for my experience, when I went to the team, the nurses and the APPs and everybody, and our goal was to improve our survival for ECPR, everybody said, oh my God, we're so strapped for resources. We've got burnout. Everybody has burnout. There's no way that we can do anything else. And then when we frame the question as, well, what kind of resources can we provide to you? How can we support you in understanding ECMO? That opened up this whole nother space of education that the APPs and the nurses really took to. And so this is our final maintenance of ECPR education, because they were all getting an initiation exposure when they onboarded at Duke, and then no maintenance. So we now have slides and materials that are on a shared drive with our new algorithms for people to look at anytime they want to, and it's circulated on a regular basis. We now have a new skills course, 2 hours every 6 months. It has a didactic component of ECPR and ECMO, who, what, when, where, why. What are the contents of the cart? This is on a slide. And then what are the roles of the team members? And then we have a hands-on component where they review the carts and equipment and then simulation. We are very excited that we'll have a bedside hospital drill in the coming months once we get through all of this maintenance. And it's going to be a daytime deployment of ECPR. And we've created metrics, time to arrival of perfusion, time to arrival of the ECMO cart, all of that stuff, because we want it to be iterative and continue to identify the holes in the system. So, you know, that debriefing at the end of the ECPR where it's all the stuff is glaring you in the face that you could have done different, and then rinse and repeat. So all materials are shared, and we're going to maintain these skills courses every 6 months. So this is my last slide and comment about QI and system improvement, and specifically this ECPR experience. This is the way I organize my QI, which is a book that it's just a way to keep yourself accountable. It's called Measure What Matters, and they have OKRs, so objective and key result. And so I've created these for our QI project. So for this particular initiative, our objective is to improve survival for ECPR outside of the OR and ICU. Again, the survival was half that of the OR and ICU. And the key result, decreased time from ECMO page to cannulation by 50%, and improve resuscitation by the code team, which specifically means that every patient is getting the plasma-lytic red blood cells and epi drip. So, you know, that list is very long, but I just wanted to give you some language and direction about implementation. And thank you so much for your time.
Great. Thanks so much, Dr. Zwischenberger. That was thought-provoking. You know, we'll move on to our second question. Who performs ECPR at your institution? We have several choices there: cardiac surgery, ER personnel, cardiology, and multiple teams. And Dr. Zwischenberger, we're waiting for the audience to respond. I would pose that same question to you. How have you guys really limited the initiation of ECPR to the cardiac surgery team? And if so, is that a continual discussion you are having to have? We have found that it is a recurring theme here. And how are you involving the other service lines in the quality review? Is the ER involved?
Well, so the short answer is the cardiac surgeons only are doing this. One of our thoracic surgeons does also take call. And I think there's discussion around an interventional cardiologist participating, but that has not, Jeff, do you have updates on that? But no, not the ER. I mean, the ER, based on the way that they are requesting ECMO, would be every other patient. So we were pretty concerned about having,
Yeah,
Jeff?
I don't, we currently it's all cardiothoracic surgery. I think there are other models that systems have found success with, or at least, you know, a successful process with. I think some of the real challenge becomes that, sort of like I mentioned, it's cannulation is sort of one step in literally hundreds of steps that have to happen in the care of ECMO patients. So it's also a decision of how you're going to manage your system, not only for the cannulation event, but the care thereafter. And in our system, the VV patients can be managed in the MICU or in the cardiothoracic surgery ICU, and the VA ECMO patients are managed exclusively in the cardiothoracic surgery ICU. So it's been sensible to sort of limit it there, since ultimately the patients are largely cared for on the cardiothoracic service thereafter. But there are other models that work. So
yeah, absolutely. I think that makes sense to dovetail initiation with continuity of who owns the patient afterward. So with that, I know we're trying to get in all the talks, and then we'll have a more substantive discussion afterward and with questions from the audience. I will turn it over to Dr. Jason Smith.
think some of the questions are being answered by our panelists already. That's a good thing.
Great. Dr. Smith?
Can you all hear me? Yeah, great. Well, thank you again for inviting me to participate. I think we've heard a lot about ECPR and the specifics at Duke and their expertise in this field. I'm going to talk a little bit about team building and resources and focus this sort of my concept of the tiers of service of ECPR and how it can fan out. And I broke it out like this. I think most established ECMO programs do either informally or formally provide some level of ECPR in the OR and cath labs. I think if we're already doing ECMO routinely, it's a natural progression to try to salvage patients in this manner, and most programs are already doing that. When we look at the rest of the hospital, the in-hospital environments, whether it's the ICUs and the ER, hospital-wide, I think these largely represent a linear expansion of resources to what is already established in ECMO programs. But the exponential jump is moving to out-of-hospital ECPR, and that's really what I was tasked with today. And I will caveat that I am not an expert in out-of-hospital ECPR. I think there aren't a lot of people who have done this. There are a couple of programs. What comes to mind is the program in Minnesota and Southern California at UCSD, who may have some institutional expertise in this. And more widely, there's an NHLBI white paper looking at the issues around out-of-hospital ECPR, and those are documents that I've gone to for this talk, and would encourage everyone to review. Briefly, because you've already had such an excellent talks about in-hospital ECPR, when we think about the expansion of ECMO application to ECPR in programs that already have ECMO programs, these are the questions that I think really need to be asked. What is the availability for cannulation? You've already heard how Duke does it, and I think they've stressed the idea that having rapid application of cannulation, the rapidity of cannulation impacts outcomes. And so moving towards an in-hospital model, I think, is really critical. And whether that's CT surgery, cardiology, employing ICU physicians, the ED fellows, if it's a educational environment, or even involving the general surgery pool, are all options depending on the practice environment people are facing, whether it's a community environment or a university. And thinking about how to utilize these different resources to staff up that growth in an in-hospital ECR program, I think, is really important. Obviously, education for any of these groups that don't routinely do ECMO currently is crucial, as Jeff mentioned, to avoid the many complications and complexities that can evolve after an ECMO cannulation. But as a frontline team for cannulating quickly, I think these are options. The next big thing that has to expand in an in-hospital environment is equipment and logistics. We all know that perfusionists are a limited resource, and having in-house 24/7 perfusionists often limits access to functional operating rooms and so forth. So whether your institution has the resources to have 24/7 in-house perfusion support is a big question. And looking at other options like ECMO specialists and VAD coordinators to supplement that pool, to be the person to manage bringing those supplies to the bedside and to the patient in need is really critical. That's, again, an expansion of expertise, expansion of a number people that need to be educated and trained to support this kind of endeavor. And then thirdly, as has also been mentioned, the management. How are you going to manage these ECMO patients once they get cannulated? Are they coming to an ECMO service or an MCS service, or are they going to go to general cardiothoracic surgery? Is there going to be a single unit that accepts all of these patients? Are they going to be dispersed throughout the hospital in different units? Those are major logistic questions that have to be hammered out. Obviously, the advantage of a dedicated unit is the elevation of the expertise in that unit around management of ECMO. But obviously, these patients also have to land somewhere when they're cannulated in the emergency department or in the field or in the cath lab or in a floor setting. And if a CT ICU bed isn't available, are they going to be able to make space and or have a dedicated landing spot for them? So these are really challenging questions, but largely represents just the scaling up of resources that are already in the hospital. The more challenging question, what I'll spend the rest of my time talking about, is out of hospital ECPR. And I kind of broke this into 4 sections to think about. One is assessing the community resources, developing a consensus for using ECPR, planning the logistics, and program evaluation. So assessing community resources, I think the first question that really needs to be answered is ECPR the right next step? And Mark kind of alluded to this in his introduction, but you know, is it really appropriate to establish an ECPR program in every community? And I think each community needs to think about this for their population, because there are some basic things that have to be accomplished before ECPR will add value, as you heard earlier. One, there has to be effective penetration of bystander CPR training so that there's early and immediate restoration of circulation. And without that, implementing an ECPR program won't impact outcomes in the long run. Then the trained response of BLS or ACLS in the community needs to be at a high level so that the next progression in therapy and attempts at restoring circulation can be made, and that there's adequate personnel to immediately transport patients. And that there are expertise that can be trained to the level of being able to cannulate for ECMO, which is a big question. Are you going to train paramedics to cannulate? Are you going to put physicians in the field? Are you going to put some intermediate provider like a nurse practitioner or a PA in that position to be cannulating in the field? Those are all important questions to ask. Then, what are the ECMO receiving facilities? Is there an adequate ECMO program in the region that can accept all of these patients? You know, if you're going to have people cannulated in the field and put on ECMO, then the emergency room that's receiving those patients can't go on divert. You know, there has to be a place for these patients to land once they're put on ECMO, and maybe more than one facility. And if there are more than one facility, if there is more than one facility in the region, how do you decide which facility they're going to go to? Will EMS response times already be optimized to initiate conventional therapy and improve outcomes? And is there a strong structure in place for training these EMS personnel? So I think all of these questions need to be answered. And if there are areas that can be optimized prior to moving to ECPR, then those need to be pursued. And I think it's also fair to ask, you know, outside of the things that specifically apply to ECPR, are there other public health measures that are more important for any given community to address before addressing ECPR? And those are, I think, important to get good buy-in from the community. And there's also important questions about who will bear the financial burden both of program development, the initial outlay that's not going to be reimbursed. Is that going to be grant-based? Is that going to be philanthropy-based? Is that going to be out of the budgets of the community and taxpayer monies? And who's going to cover the ongoing costs of this effort? Again, the community or the healthcare community. Then I think consensus development is the next big important thing to consider. And we look at the stakeholders. I think the citizens in the community are the largest stakeholder, both because they're likely to be the ones to gain the benefit of this endeavor and also bear the costs of the endeavor. And so they must have a large role in deciding how this unfolds. Community leadership with insight into the finances and the capabilities of the community is important. EMS leadership and the hospital programs that will be involved. And all of these need to be at the table in deciding the next few questions, like who is a candidate for ECPR? You heard some of the criteria earlier. I think for out of hospital, it becomes even more critical to have a hard line protocol so that there's not confusion in the field about who gets cannulated and who doesn't. And some of those considerations around the age of the candidate, size, medical history, downtime, how much conventional CPR, presenting rhythm, etc. The list could be significant, but needs to be easily discernible in the field. And then other questions that I think will be considered and need consensus around how ECPR will be used in patients that don't recover neurologic function. Is this going to be considered as a bridge to organ donation? What is the destination for ECMO supported patients? How do you disperse patients between facilities that are willing to take ECMO patients? Is there a good communication protocol so that receiving facilities are alerted early in the process and can participate in the management early of these patients? And then there also needs to be consideration of the termination of ECPR. If a cannulation results in poor ECMO flows and lack of perfusion, then persisting with a disastrous cannulation and ECPR situation is probably unwarranted, and consideration needs to be made about how to manage those sorts of situations. I've already mentioned in logistics, where will these patients go once they're cannulated in the field? One facility or many, and how do you distribute them? Will it be based on geography and the closest center, or is it based on the center's capacity at the moment-to-moment capacity, and who will direct those kinds of decisions? What geography will be covered? How much response time is allowable? Response time for first responders, response time for ECPR teams, and distance to receiving facilities. Gaining an understanding of how many cases will be expected based on where you set the bar for who the candidates are and what the population size is will help set the needs for expectations on staffing, both in the field and in the hospital programs that will have to be scaled up to receive these patients. And then lastly, also Brittany had a nice insight on developing a registry and measuring your quality metrics, because tracking your outcomes is crucial to quality improvement. And especially the major, I think, issues looking at out of hospital resuscitation will be neurologic outcomes and major vascular injuries, and being able to track those and improve on those. And based on that type of registry, developing a national standard for program performance, perhaps provider certification programs, and ultimately community feedback and oversight, maintaining transparency into both the positive and negative outcomes of a program like this, the costs, and allowing the community to have a say in how that is distributed among the community. And that's really kind of the questions I came up with around this topic, where there's a relative lack of data. So happy to entertain the conversation around that provocative topic.
Yes, Dr. Smith, certainly more questions than answers. I think that's kind of the impetus for this webinar. We'll bring up our last poll here. What is the downtime limit for utilizing ECPR at your program? I constructed this specifically really talking about out of hospital arrests. So, please respond with that in mind. As we're waiting for the responses to come in, the thing that strikes me is that this is never going to be a therapy, as you were alluding to, Dr. Smith. It's available at most centers because the activation energy in the teams and resources is just so high. And so with any life-saving therapy, I feel like we want it to be reproducible, the results of it, and we want to maximize its availability. And so I would be interested from you, and obviously you can respond first, and I'd be interested to get the take of the other panelists. Have any of you, as you're developing your ECPR programs and coming up with guidelines, been participating or spearheading any community consortiums like you're alluding to that really create a hub and spoke model for these patients and involve EMS to a high degree, much like we've instituted with STEMI centers?
Well, first part of that answer is no. I haven't been involved in any, but I do think the STEMI program model is the right one to follow, in the sense of trying to hub and spoke the response to a critical time-sensitive medical problem. And in fact, the NHLBI white paper referenced that, modeling an out-of-hospital ECPR system on the STEMI model, or an ECPR system in general on the STEMI system, for sort of program evaluation, national benchmarking, and so forth. So I think that's the right idea, but no, I haven't been involved in that. Maybe they did in Raleigh. I don't know.
Yeah, in Durham. Yeah, we did our ECMO utilization basically around 2014, 15, 16. Monty Donishman, who was previously here, did the hub and spoke, and our ECMO utilization went sky high. I mean, like our highest ever. And then it's trickled down, and that's where our guidelines have really kicked in, because we did generate all of this data from those years, but it was from basically like 2017, 18, 19, 20, the rest of us started to get a little bit more discerning about it. And, it was obvious who wasn't going to do it. But 2015, 16, 17, we were super aggressive. The fellows were out to cannulate with the hub and spoke. And what we had was that the fellows were cannulating and then coming back with perfusion. And we were training all these the spokes to how to rig a ECMO machine for their patients. And what we learned is, one, it was really interfering with our ICU, right? Because we just got totally bogged down in the ICU, because we had cardiac cases, because we do have regular cardiac surgery going, and the VA ECMO patients had to be in our ICU. So we were canceling cases to get in basically a dead patient, right, from another hospital. That was one thing. And like I said, our guidelines helped us become more discerning. And then we have trained enough of the other hospitals to have their ECMO circuit relatively put together. And Jeff, you should definitely comment more of where we are now. I just lived through it for a few years, and the perfusionists are going up to pick up a cannulated patient. Which has been much less of a resource burden.
Yeah, I think as Brittany alluded to, we were doing a lot more of that 4 or 5 years ago. Actually, when I was sort of coming through and training, frankly, I see one of these questions is asked in the box. We had very limited success, particularly if a patient had been cannulated in the ECPR situation, with our transfers in from the outside hospital. So Increasingly, we've gotten, more selective with that, and we've tried to push it towards, if there's a patient, this isn't relevant to ECPR, of course, but if there's a patient who's doing poorly that another center thinks they need ECMO, that they conference call us in, and, we kind of have a shared game plan before we go that route. And we have, there's still times where it needs to be considered, but there's no question that we haven't had great results with the transfer in on ECMO patients.
Well, and I see Dr. Slaughter has a question here, and I just wanted to also ask you, Dr. Keenan, in your efforts with outside hospital education, did that include kind of trying to maximize the quality of EMS care and high quality CPR? I mean, as that paper in the New England Journal suggests, high quality CPR may be the biggest determinant in all of this, especially.
Well, yeah, I'm going to answer your question in somewhat of a tangential fashion, because I don't know so much about the education at other centers and so forth, but as I'm sort of thinking about this talk, and actually right now in our conversation, it sort of occurred to me that I think our in-hospital sort of RRT team, rapid response type team, that system has gotten very good, in my opinion. I mean, the infrastructure to identify patients who are doing poorly on the floor and intervening, before the code event, I think has dramatically improved, in my experience at this hospital over, 10, 12 years. And I've just noticed that. And I think probably we're avoiding some arrests, and that may just be, limiting our denominator of salvageable people, if you would. So I think when Jason talks about, well, where's the best resource to be spent to maximize, say, people that are, it may be that coming up with a robust, sort of RRT program to identify patients before they code is a high yield,
Yep. Dr. Slaughter, you have a question, sir?
Yeah, relatively quickly for all of you, because I think there's also a couple underlying themes, and even in the Q&A box, the idea is anybody can cannulate, right? But the issue is that's not a program. And Jeff, you alluded to it, or actually specifically stated it, though, is before you cannulate, you really need to have an idea of, what you're out, right? I mean, because many times, in particular, I think also what Brittany's alluding to, we get them too, outside hospitals, want to do it, they want to save everybody, and they put them on, then call you, and there's clearly no out for the individual, right? They're not going to get myocardial recovery. They're not a transplant candidate, and they'd be a very poor VAD if ever possible. And so we end up with lots of people cannulated, where in reality was they had very little chance of survival. And then, as you say, they clog up the ICU. So even the idea is lots of people can cannulate. But I think one of the fundamental issues, and what you all have done very nicely, though, is right, you call and find out, are they a candidate for something else if they survive? And I think that's a very important component of a successful program.
Yeah, I wholeheartedly agree that you've got to dovetail the decision making to the people that really are responsible for the outcome and the long-term care of these ECMO patients. That seems to be an underlying theme in all the presentations and our experience as well here at University of Mississippi. Dr. CJ, I see you have a question, sir.
Yeah, just to reiterate what Dr. Slaughter already discussed, I think he has pretty much clearly said what not everybody should be doing. ECMO, unfortunately, like at least both in Emory and Cleveland Clinic, at least in the Cleveland Clinic, you say that not everyone, we used to come to say that not everyone should have ECMO before going to heaven or hell. Is a funny thing. I mean, you don't have to crack open the chest for everybody there, and you just have to be very conscious and cognizant about which patients are supposed to get. And regarding the teams, there's a lot of question in the Q&A section about who are the teams that can think. Sometimes, apart from the cardiac surgical teams, many people think that ECMO cannulation is also a kind of a bigger cannula, like a bigger central line insertion, which is not the real case in real scenario. I think it has to be limited with expertise over the things. And lastly, another thing is, what is to all the panelists here? What is your preferred LV offloading modality of choice between a balloon pump versus Impella?
Oh, yeah.
Go ahead, Jeff.
So I think Impellas are superior for offloading. I mean, there's no doubt about that in my mind. The CP device can be placed pretty quickly, you know, through the femoral artery. And the issue with the CP is there's high hemolysis rates, but we found when we have a patient on ECMO, you just run it at low speeds, you know, P3, and you just get decompression. So that's often a first choice because it's most expedient. But if we think the patient's really viable, and particularly if we're going to try to downgrade their support to just a single ventricular support, the 5.5 device is excellent for that. There are times where you don't need it, where you've got enough ejection. So, you know, we'll typically target, you know, at least 10 to 15 millimeters of mercury. So you can manage that with inotropes. And then there's times where Impella is not an option, you know, if there's LV thrombus or some other anatomic feature. So in those cases, a balloon pump can help a little bit just by offering some offloading to the ventricle. I don't know if you have other thoughts on that, Jason, or things to add.
I think about it similarly. We take a bit of a collective approach. You know, if they have some LV contractility, then inotropes or a balloon pump may be sufficient. If otherwise, an Impella is a great option. And then if an Impella is not an option, as Jeff just mentioned, then an atrial septostomy is another option to offload.
Well, great. I think that that was very well put, Dr. CJ. ECMO is not a glorified central line.
Well, another thing I want to ask is, like, to the panelists here, is what is the incidence of these ECPR patients ending up in getting a transplant in both Duke and UCSF? Are you going to follow the same status 1, status 2 concerns for the things, or is it a special route you take for the ECPR patients?
Yeah, or I would also broaden that out to which patients also receive, you know, durable mechanical support in the form of an LV.
Well, in our experience, the patients who are getting ECPR, the opportunity to take them most of the time, the opportunity to take them directly to an advanced heart failure therapy, be it transplant or VAD, isn't there. I mean, usually these patients are acutely in a terrible state. There's often accompanying other organ injury. And so, you know, like I said, I think our first goal is to see, well, can we maximize our chances of native recovery? Because they're usually not going to be a transplant or a VAD candidate immediately. But if you can't get native recovery, then it becomes a process of trying to turn the patient into an advanced heart failure therapy patient. And that usually means stepping down to an alternative form of support if you can get them to a univentricular strategy. Or we've taken a few patients to peripheral BiVADs, and, you know, that's sort of expanded the window, you know, can support them that way for, you know, weeks to even months while we rehabilitate, while we wait for kidney recovery and things like that. I can't say, you know, clearly, I mean, I showed you our outcomes. We don't succeed. You know, we do not succeed the majority of the time, but we do have, you know, cases of success there. I don't know if there's other thoughts.
Well, I think that when we're talking about ECPR, at least out of hospital ECPR, and probably to some measure in hospital ECPR, we're talking a lot about rhythmic arrests or ischemic arrests, which if they get high quality CPR and you restore blood flow, often the ventricle will recover enough to wean off ECMO if they're going to be salvageable. So I think that situation arises less often, as Jeff said, where you're trying to decide whether you can take an ECPR patient directly to an advanced therapy. That said, we've had 1 or 2 this year that have gone from ECPR to, you know, recovered enough that they've got good neurologic function, good end organ function, their hearts are just recovering. Small ventricles, couldn't get a VAD, and so ultimately transplant. There's actually one I can think of this year that went like that. So it happens, but I don't think it's the majority of cases. And these are such, each patient is really complex and unique. And I think until we have a huge national experience, it's really hard to generalize some of these things. Because once you get them on ECMO, things can go in so many different directions in terms of their complications, their, do they develop LV thrombus? And it's just really, it's hard to generalize.
And okay, everyone. Well, listen, we'll wrap it up there. I know that we want to be respectful of everybody's time. We were over a little bit, but the discussion was great. I just want to take this opportunity to thank our panelists, Dr. Jeff Keenan, Dr. Brittany Zwischenberger, and Dr. Jason Smith. I applaud you guys' pioneering efforts that hopefully will supply some of this data that will help the rest of us make good decisions as we kind of plow forward in this field of ECMO and ECPR. With that, this is certainly the beginning of the discussion, not the end. More to come. I will turn it over to Dr. Slaughter. Thank you all again.
Similarly, great presentations, great discussion. I want to, hopefully we answered a lot of questions. We had 161 participants, and I know that all of our panelists would be happy, to engage in additional conversation, because we want to make sure that as we use this technology in these basically high-risk patients, that we use it appropriately and do what's best for the patients. And then lastly, also, I want to thank CTSNet once again. They're a tremendous partner for these webinars. So thank you once again, and a great webinar.
Thank you all. Bye-bye.
Bye, guys. Thank you.
Thank you for attending this ASAIO Journal webinar held in collaboration with CTSNet. You can check out past webinars and publications from the webinar participants at ctsnet.org, along with hundreds of additional cardiothoracic surgery videos. As a reminder, a recording of today's webinar will be available next Monday on ctsnet.org and CTSNet's YouTube channel. Have a wonderful rest of your day.